Emeritus Professor in Department of Clinical Medicine, Faculty of Medicine, University of Colombo. And I warmly welcome you, sir, for this session, and we are waiting to hear your enlightenment today for the field of social work derived from health care work. And also, to say a few things about sir's work, he always had a diverse perspective of patient care management in the perspective of person-centered management. So it's over to you, sir, for the presentation. Yes.
Thank you very much for giving me this opportunity to speak to you. So I will be looking at some of the issues which are important from the perspective of health. And some of the challenges that we are facing in the health sector. So it is based on Sri Lankan experience, and it will be hopefully relevant for Sri Lankans. One point I would like to make is that the health sector is for the benefit of the overseas participants. We have a system where the government funds health. More than 90% of inpatient care is provided by the government. About 50% or so of outpatient care is provided by the private sector. So we have free health in a sense, because the user does not pay. And Sri Lankans, I don't know whether you realize how fortunate we are, because we don't have to pay for education, nor do we pay for our health. I have done all my postgraduate degrees without having to pay a cent from my money. The taxpayers have paid. So my first acknowledgement is to the people of this country who have funded me. So the challenge we face is probably it's nothing new. We are having a situation which is evolving. It is changing. And over the past few years, things have changed a lot. And there is an increasing need for care, comprehensive care, health, social, and all those aspects. And there is a decrease in the provision of care due to lack of resources and so many things, economic crisis, migration, and so on. And if you look at the illness part, I am focusing on that because we have, for 20, 30 years, we have been looking after the poorest of the poor in the hospitals, and the sort of social support they need is enormous. So next, I would like to talk about the elements of a crisis and how we are going to respond to this crisis. So the evolving situation is given here, and then the balance between increasing need for care and the fact that we are having a decrease in capacity. So there is an increase in need and a decrease in capacity. You have heard of all this. The aging population in Sri Lanka proportion-wise, therefore the increase in chronic diseases and the recurrent acute infections and acute exacerbations we have. So that's one, the increasing need for care. And on the other side, you have a decreasing capacity because the care which is provided by the state sector is in hospitals and clinics. We have a very good preventive health sector, the MOH system, for maternal and child health. But when it comes to curative care, we have a deficit. So we have less resources, and we are having a fall in the number of carers. That's where migration comes in. There is an exodus of qualified health workers. There is an exodus of carers. There is a large number of young people are going and leaving the elderly people here. They are going to look after the elderly overseas by leaving their parents to be looked after by someone else. That's the irony. Right? And families are shrinking. My parents had 7, 8 brothers and sisters. I have one. My children have one. Right? So families are becoming what we call nuclear. So there's migration, families are changing, there is female employment. And females who are caring for families and members of the family are now gaining employment in factories or as domestic workers or going overseas. So you can see that we are heading for a crisis in care. Health, social, psychological, moral, we are heading for a major crisis. And when it comes to the health sector, of course, we are looking at the illnesses. And there are unreached populations. We were discussing about that yesterday. The chronically ill are not covered properly by social care. We give a few handouts, but otherwise it's not comprehensively covered. You can have an accident and break your spine, and you might get a few thousand rupees. You can get a stroke, and there isn't care in the community. No one is coming for physiotherapy. No one is coming from the state to feed you. You can be 90 years demented and living at home. There is no one helping you if you are alone, other than the neighbors and the family. So we are having, in the health sector, if you look at the health sector, we are having a major crisis which we have to face. And the next few slides is based on our work which we have done. Because we have been sending our students to the community for past 20, 30 years. It was started by Professor Sharif. So when a person is very ill, we say gets a stroke, the students visit those families, and some of the families are living in places like that in Colombo. And when they visit those places, it's transformative. Because you must remember, some of these children who become doctors and nurses have never stepped into a poor person's home. Some of them now, in our generation, we walked, we went by bus, we have slept on the floor, we've done everything. But now you get a generation who have never gone in a bus, have never gone to a market, have never spoken to a poor person, never stepped into these areas. So it's transformative and it changes. And when we look at it, these are the sort of problems the students have identified. Now this is important because this is where social workers come. This is where social workers come. They are giving you information from the ground, 20 years experience. These are the problems faced by people who are ill, who have been discharged from hospital, stroke, heart attacks, whatever. And when they go, they have to face their medical problems, they have physical problems, they can't walk sometimes. they can't access healthcare. Some of them are on the 4th floor of a flat given by the government and there's no lift. So you rely on someone else for the medicines. Personal habits, drug dependency, smoking, alcohol, mental health issues, lack of recreation, you're trapped in some of these small households. Living arrangements, people sleep on relay in small houses. Some people sleep at a particular part of the night and the next batch takes over because there's not enough room. Food is scarce. Housing, there's overcrowding. Common toilets are being used by some. Of course, now majority are having toilets, majority having some sort of electricity. But during the crisis, now with the increase in prices, the poorest of the poor are losing their electricity because the government is disconnecting if you don't pay. This last week we had a situation like that in the world. Floods because of climate change. Social aspects, loss of employment. When you lose employment, there is nothing in the state, you give a few thousand rupees, right? You don't have any social support in that sense. As a result of the crisis or illness, children will stop going to school because they have to look after the parents or to get employment. There is loss of connections with your neighbors, with your families. Luckily the mobile phone helps, but social networks get disrupted and there's discrimination, especially in mental health. She will tell you the details of how people are discriminated, stigmatized with the mental illness, especially with the mental illness. And of course we have hazards, issues of safety, waste collecting in those environments, floods and so on. So these are some of the issues the students identify, and these are some of the things which, if you are really having a comprehensive social worker network, you can help. So then I focused on illness. This is based on a paper I wrote because the illness, even though our health system is supposedly free, there are costs. There are direct costs still. Sometimes the drugs are not available. Not much better, but some of the drugs are not available on time. Some of the tests that cannot be done in the government sector. A good example is diabetes. The state does not give free tests for HbA1c, glycosidated hemoglobin. Basic test to check the blood glucose, average blood glucose, because that's costly. So there are direct costs and there are indirect costs. Now this is again important because transport costs have gone up. So each time a patient comes to the hospital, they have to sometimes take a 3-wheeler or take the bus. And you can imagine when they come there and there's trade union action in the hospital. Right? 2,000, 3,000 rupees. They come to get their medicines. So there are indirect costs. In addition, you lose your earnings, and when you are ill, you are not productive. So we have a crisis, and when it comes to illness, we are having another major issue because of the costs and lack of carers. And the third one is from my PhD actually. We looked at how illness will drive people into poverty. Right? To be brief, I will just tell you that poorer people are more likely to be ill, and when there is increased cost of care, they are unable to cope, and when they are unable to cope, they become poor. So illness can be a cause for worsening of poverty or pushing people into poverty. So unless the social care system cushions them, we will be driving people into poverty because of illness. And we know that more and more people are elderly more and more, chronic diseases more and more, obesity, alcohol, tobacco. So we are getting an epidemic of chronic diseases, and unless we support, we are pushing them into poverty. And transport costs, private sector help, all these worsen this move towards poverty, and certain things cushion it, and you will see the most important factor which cushions us in Sri Lanka is the fact that public sector provides free health. So when people compare and say Sri Lanka is not doing well, we are not being paid adequately compared to some other country, that's wrong. Because in those countries you are paid more, but you pay for your health, you pay for your education. You can't just select your parameter and then compare. We were comparing to Bangladesh a few months ago. My colleagues here, we were very happy that Bangladesh helped us. So when Bangladesh was doing well, we were saying, oh, Bangladesh is doing this, that and the other. We are useless. Now Bangladesh is in crisis. And those who compared Sri Lanka to Bangladesh are now silent. You can't compare. You can't just compare your parameters. So, free health is cushioning us. And this is the whole framework which puts everything together. So, illness is a major issue which will push people to poverty. And unless we supplement this free health with good social support, we will still be pushing people into poverty. So what's the response to this crisis from an overall point of view? Politicians will say it's economic development. Economists will say economic development. Then some would say not only economic development, you have to spread what you have benefited, equity. And in addition, others will say, no, we have to develop, there has to be social development, more emphasis on prevention and promotion. All that is good. But from our workshop point of view, I think we have to look at how social support can help us in this crisis. So my argument is that we are facing a huge crisis. It is affecting the health sector, and one important intervention would be through the social support. Now, how do we do that? We can think of various ways, but I think the low-hanging fruit is to link the social services sector to the health sector. Because in our health system, people are not thinking about accessing the social services. We don't have social workers in all the hospitals. We have a few in psychiatry, in stroke centers and so on. But it is not a system-wide thing. The health professionals, the doctors, nurses, are not aware of some of the social support people can access. The patients are not aware of what to access and how to access. Patients are, when they are sent with a letter to the Grama Sevaka, they have to walk to different places, and see, transport costs are there. They are looking after another person who is ill in hospital. You are trying to struggle and survive. Now you are supposed to go take a piece of paper and go to the Grama Sevaka and try to get your works on the doctor. So there is the gap between the social services and the health system has to be bridged. So I'm asking 4 questions. Can we place social workers in healthcare institutions? what are the problems we will face and how can we solve them. That's the first one. Second one, how can social workers partner with healthcare workers? How will the social workers link with the healthcare workers? Third is, how can social workers help patients in healthcare institutions? The fourth one is more of a policy. That is, what are the steps to in this process? I must tell you, we've been trying to do this for the past 12 to 15 years. We have had meetings with the social services, we have had meetings at the Ministry of Health, we have developed position papers, concept papers, discussed, but if the last bit is not moving. So I am pleading with you from the social workers' point of view, you all have to push. You also must push that you want to be deployed and work closely with the health sector. Because if we do that, at a system-wide, there will be a change. We will be able to help in this crisis. And when I was invited, I took this up because I think it's important that the social services sector gets ready with this. We are having elections in September. New government, whoever comes does not matter to us. We get a new government. New government during the first year, that's the window where you can push new policies. You can push new policies. There will be a new Minister of Health, whoever, whichever party. If we push at the correct time, we can make it. The administrative work and things have been done, so the background is there. We need that last push. So my suggestion is that we work in groups. Each group gets one. I think then you can spend more time. See, just one topic. Group one can take the first topic. Group 2 takes the second topic. Group 3 takes the third topic. Group 4 we can leave. I mean, we can do that later. I will show a slide. I have worked out some of these in my own way, but I won't contaminate you. We will do it as group work, and then I will also share my ideas. Is that okay by the organization? Thank you. Thank you very much.
Now it's time for 5 minutes to 12. This is the lunch break. So we have the lunch break starting 12:45, sir. Now it's 5 minutes to 12. So if we give each group to 20 minutes to discuss the one question, that would be enough, I guess. Yeah, before lunch I think it's better. So now, who is going to take, I think, any volunteer to take questions, or do you want me to go by the order? Okay, they take one. Three. Four for everybody. Four for everybody, okay? Right, now shall we start the group discussion? I'll be also visiting and let's
I will just show you the next slide because this is the sort of background work which has been done. So when we talk of placing, that's group 1. Group 1 is which group? I. So, first question is, should we be placing social workers in hospitals and clinics? Start with, we can think of the hospitals first. What are the problems you are likely to face and how do we solve them? Pay, designation, who will pay you because you are in a different place now? Right? You understand, these are, and do you require special training to be in these places? Yeah. So you all have to discuss this, right? And think of possible, you know, I mean, you will have to have certain things which can be done low cost almost immediately, plus the ideal. You can think of health social workers, medical social workers, what happens in NHS in UK. That's far, far away. You won't get that in October 2024. Right? So that's one. What we discussed with the Ministry of Health and the Social Services Department is for social workers who are paid by the Ministry of Social Services. They are sent to the hospital and you have a hospital desk or an office every day or certain days of the week, and they are paid by the social services. Because if you try to develop a new cadre, you have to go to Treasury. You won't get it. If you are going to shift new cadre to the Ministry of Health, you won't get it. Trade unions are going to protest. So you have to think of practical things for Sri Lanka. Then second one is, how are you going to partner? So is it a visit or is it a desk? Who is the link person? What about the AR and administrative AR, FR, you know, the whole list of things which you have to sort out, right? So that sort of area.
Can I ask you?
Yeah, sure.
How about community networks? Because most of the VBC patients, like senior citizens, they base in community level.
Yeah, you see, you know, this is, I've worked on this area a bit because this is what we have now. So a patient has got a stroke and is in hospital. You want support. That patient has to go. Go to the office and find the place and access. But what we are saying is, can't we get a social worker to come here?
Exactly.
The hospital. Part-time, full-time, visiting, but system-wise. See, when we talk about this, suddenly the neurologists say, we are doing it in stroke units. That's not the idea. The idea is system. Link up the two system. Right? And then, because that helps the social worker here to link up. So patient is from, you know, and we have free access. Another unique thing in our Sri Lankan health system, if you go to Mulatin tomorrow and you want to enter hospital, no questions asked. You are in Mulatin hospital. You go to Hambantota hospital, the next day you will be treated just like any other Sri Lanka. There is no, so if the social worker there should be able to connect and say, you have these things you can get, these are the things you can get, these are the places. And if the communication network, nowadays communication is improving, like these are online, things will improve. Then you'll be able to tell this person to go and meet such and such a person in the office. You see, we don't realize how helpful that is. You don't realize how helpful. How many calls do I get asking which doctor to go and see? where to go for the test, I would have been asked 100,000 times. And I provide that information, but that information should be available. So social, this is a worse scenario because these patients are really, some of them are really poor. They don't have access, they don't know anything when they come to hospital. So that's what I meant by, then how do we partner with healthcare workers? Again, we thought through quite a lot in these discussions. Have a desk or office which is loaned by the hospital, right? What is become important administratively? The first question they ask is who is going to supervise the social work? Hospital, we don't know who is going to supervise. Keep the supervision with the Ministry of Social Services. Don't try to mix. Just ask for a desk, an office. We should develop a printed form. There should be someone who refers. So you say, right, these are the criteria. Only consultants, specialists are able to refer a person for social support. Later on it can develop. Initially keep it at that level. We went to the level of actually drafting a referral. Okay. So you keep the original with the patient and one goes to the is kept in the ward, one is given to the patient. Social worker is in the office. The patient goes and meets, or the carer goes and meets the social worker, who is now in the office in the hospital, who refers with the appropriate place. So that's the framework we thought would work well. How can they partner? How can they, well, this is almost the same as well. This is the sort of form we developed. So you have certain basic data, and the consultant, like filling the medical certificate, we did it in a similar fashion to the medical certificates which doctors fill. So that it's not very unfamiliar. You just the house officer will fill most of it, and the consultant will certify it. And this is also important so that you have some sort of screen, and then it's referred, and the social worker takes it. And that part you are with the experts. And when it comes to implementation, also we looked at it. That's group 4. A lot of work has to be done because this is something which we are discussing now. You have to get approval by 2 different ministries. So secretaries have to agree. You have to make sure there are no conflicts about designation. Right? Because one category will say we don't want to speak to the other category. Yeah. Most people don't, but there can be. Most people are not worried actually. No. You have to get all these approvals. And now there's a bit of a complication because teaching hospitals are with the ministry, other hospitals are with provinces, and social work also the provincial evolved subject. You have to think of human resource development, and that's where the institute comes in. That's where assistance from overseas collaborators come in. And then we have to educate the public. This is what you have to do. If you have a problem, this is the number. And now you would have noticed that we have very good, these emergency numbers. For example, for mental distress, there is one number which is 24/7 working at the National Mental Health Institute. all the patients who are discharged from there have that number. So they have prevented several suicides. So people have been walking along the rail track to commit suicide. Last moment they use the number. So like that, we have to think of a program way to get this across to the people. So those are some of the, so group 1, 2, 3. Thank you.